Hello and welcome on behalf of both myself, John Bagnulo, as well as our clinical expert that we're so happy to have with us this afternoon, Anna Cesati. Anna and I are going to be really outlining some of the key points to understand about a unique class of proteins today known as peptides and how they can really help improve the clinical outcomes that we all want for our patients. It's a really interesting topic for many reasons. But before we get into that, I just have a couple things to share with you all. I serve as the director of nutrition for nutritional medicinals, and Anna Sasati serves as a consultant for nutritional medicinals as well, a clinical consultant. We have these learning objectives for you today. First, understand the differences in the metabolism of peptide proteins versus intact protein sources. Then explain how peptides have very unique biological influences on our health. List the clinical uses and benefits of peptide proteins, as well as list those diseases, conditions, and areas of medicine where peptides can improve clinical outcomes. So with that being said, I'm just going to take us all back to some fairly basic nutritional biochemistry. If we can recall, an intact protein could have either a quaternary, 4 levels of complexity, to a tertiary intact protein structure, which would be 3-dimensional. That means that it's more globular. Examples of this would be things like hemoglobin, all of those different proteins that occur in nature that are essentially a ball of yarn, right? They have that very complex structure, but ultimately they're made from long chains of amino acids that if we were to unravel that ball of yarn, we'd have these long chains of amino acids that we call peptides. And peptides, again, are classified typically anything under 20 amino acids in length as a sequence. And when we break those down, those peptides into 2 and 3 amino acid long sequences, we call those di and tripeptides. So that's really it in an essence. We're talking about denaturing protein, and most peptides are made that through really simple processes, a hydrolysis type process using water to cleave bonds at certain points. Sometimes that hydrolysis is under pressure, so it can accelerate this process. But ultimately, peptides are produced from intact proteins with some sort of hydrolysis that will not only unravel that, for lack of a better description, that ball of yarn, that quaternary or tertiary structure. It's going to unravel that, and then certain sites, certain bonds or binding sites between specific amino acids will be fragmented into these shorter chains. And, when we now shift to away from the nutritional biochemistry to more of the physiology of peptides, they are fascinating in so many ways. Number one is they are absorbed in some unknown pathways. That's been demonstrated. It's a great paper that's in the Journal of Frontiers in Endocrinology, a 2017 paper that looked at, how peptides have been shown to really help regulate food intake, appetite, satiety, through their influence on cholecystokinin. You can see that at the bottom here, CCK. But what the investigators also found is that, in addition to some classic amino acid dipeptide type transport across the brush border, it was apparent that they were being absorbed in some less understood unknown pathways. So there's so much we still have to learn about these small sequences of proteins. But what we do know is that they are absorbed and are digested at a much, much more efficient level than would be an intact protein. And the reasons for that in terms of the physiological reasons they're very simple. Number one is it requires significant hydrochloric acid to unravel those intact proteins, that hydrolysis type reaction. That takes time, and we're not really afforded that time, with the typical transit time, the typical amount of time we want food to spend in the stomach. So for patients and for individuals who have compromised hydrochloric acid production, either due to polypharmacy, we know that certain medications, especially when they're presented in combination, can really take its toll on hydrochloric acid production. Sometimes that is intended by physicians to lower acid levels in the stomach. That will really disrupt protein digestion, primarily through its inhibition on hydrolysis. So that's one reason. You're going to have higher rates of peptide absorption, digestion, because there's less hydrochloric acid required. In addition to that, these small fragments of protein require less pancreatic activity. Proteases, these enzymes, that we know work on the terminal ends of protein chains, amino acid chains, I should say, that you have more significantly greater sites for that type of cleave to take place, that creating fragments of amino acids are going to have much more opportunity for the pancreatic proteases to act on these small chains. So, and then again, as I mentioned a moment ago, much greater use overall of the protein because of these factors, because you're going to have better digestion, better absorption, less dependency on stomach acid, less dependency on pancreatic activity. And so because of that, you get greater net protein utilization, which is what we're all after for our patients. And when we start to look at, that, let's just, for the sake of simplicity here to start with, let's look at just the influence that these simple factors have on post-operative stay when you compare a peptide source of a protein to its non-peptide version. We could do this with pea protein, hydrolyzed pea protein being a great source of peptides compared to non-hydrolyzed. We could do this with whey protein. Regardless, when you have a peptide version of a protein source, you have much shorter stays post GI resectioning. So again, this is typically a hospital stay where the length of the stay is largely determined by a patient's ability to get back into a positive nitrogen balance, to start using nitrogen protein, I should say, more efficiently to build back some of their lean body mass. And again, if you have a protein source that's being absorbed more efficiently, it's being used more effectively by the body, those patients will spend less time in the hospital and in an ICU type setting. So this is at the very least, this is a lot for us to consider, the advantages of a peptide source, enteral formula, protein source in general. Then we say, okay, we know that it can be delivered to the tissues and the organs that need the protein, rapidly for better recovery. Well, how effective is it at actually stimulating lean body mass gains? Well, again, a real eye-opening study that's actually in the Journal of International, Sports Nutrition, where, focus on lean body mass gains and recovery are always front and center, compared pea protein in a peptide form to whey protein. Looking at this over the course of 12 weeks, what was clear for these subjects is that they were gaining as much lean body mass and were experiencing the type of increased thickness in myofibrils that we want when you compared pea to whey protein. Hydrolyzed pea protein to whey protein was as effective in promoting the kind of lean body mass gains, that were the target endpoint. And I think what's most surprising about that is if you look at pea protein in comparison to whey protein on an individual amino acid basis, and especially when you focus on the essential amino acids such as lysine, those branch chain amino acids, which are leucine, isoleucine, valine. If you look at those four on this chart, what's clear is that they're 25%, typically they're about 25% less, those essential amino acids, in the hydrolyzed pea protein than they are in the whey protein. So you would think that the whey protein, because of the role that these four amino acids play in promoting lean body mass gains, you would think that whey protein would be superior. But when that pea protein is provided in a peptide form, it's equivalent, if not superior. So, again, just the way these peptides are used by the body is really unique, due to the efficiency with which they can be, absorbed. And it's not, again, the story doesn't end simply at gains in lean body mass, um, you know, increased gastric clearance. If we start getting into other areas of medicine, such as endocrinology, and looking at, how peptides influence insulin resistance in a diabetic patient, what's fascinating is that if you take a look at mean glucose levels, and again, I want everyone to understand that in this study, everything was identical between these two populations. You had one that was receiving the exact same enteral formula, but the protein, the percentage of calories, the grams of protein, all the ingredients were the same, except one was receiving a hydrolyzed form of protein, and the other was receiving a non-hydrolyzed form of protein. And when we look at this with pea protein, you can see that glucose, mean glucose levels here at these different intervals, is considerably lower in the hydrolyzed or peptide form of protein delivered in this enteral formula. So when the percentage of calories from carbs, protein, fats are the same, the ingredients are the same, everything is identical with the exception of a peptide source of protein versus non-peptide. Ultimately, we get much better glycemic control when a patient is using an enteral formula that contains a peptide source of protein. So that's, again, this is a game changer in my opinion for so many areas, and insulin is even more important than glucose. And we always get focused on things like hemoglobin A1C and a fasting glucose level, but really insulin is where, we should primarily focus, because insulin is what has so much control of over other areas of health. But you see the same thing, much, much lower insulin levels at any given time interval. I mean, the 90-minute time interval is really incredible, because you're looking at, about a 30%, in comparison, you have about 30% as much insulin at 90 minutes as you do with a non-peptide source of protein in that enteral formula. So really eye-opening things here with respect to diabetes care, and patient management. Now, why is this? Why are we seeing potential influence on things like glycemic control? And as we're going to look in a minute, over blood pressure, hypertensive pathway, how is it that these peptides are anti-inflammatory? Because these are all really clear and have been illustrated in now a large number of clinical papers. And the reason is they're bioactive. These peptides, and look, if we look at protein in general and we look at the role that amino acids play in health, it's typically oversimplified, right? I mean, I think we've all taken courses on the differences in protein sources, and at the end of the day, I mean, more often than not, it's oversimplified from the way it's taught. Amino acids and non-essential amino acids, but we're never really taught the roles that some of those play in terms of our physiology. I mean, the role that arginine, for instance, plays in nitric oxide, dependent pathways and blood vessel dilation. It's just an example. That's not what's typically taught. It should be. And it's the same with these peptides. They're very bioactive. So they have the ability to intervene in a large number of physiological pathways in the body. And one of those that's been most well studied and understood now is the ability to inhibit the ACE pathway, that angiotensin converting enzyme, which we know is critical to, for blood pressure regulation. Most of the research now on hypertensive patients receiving peptides, especially hydrolyzed pea protein, has shown that it has a very unique ability to lower blood pressure through its inhibition of that angiotensin conversion. So again, this is just one example. We know similarly that it can work as renin does. So there are multiple points here in that pathway that ultimately lowers a patient's blood pressure, and it can be a really important, critical part to helping patients with hypertension. These bioactive peptides, I mean, the reason they're bioactive is that they have a certain molecular weight, and they have a charge at one end of those 2 or 3 amino acids. We know that a lot of, for instance, we know that a lot of the most bioactive peptides have really strong hydrophobic ends. So they have an amino acid at the end of that 2 or 3 amino acid sequence that's really hydrophobic. And that tends to drive more of the bioactivity in these molecules. But there really is no area of medicine where this isn't applicable. As I mentioned already, with respect to the endocrine system and glycemic control and lowering insulin levels, it's clear. Skeletal muscular for improving bone density as well as lean body mass. Cardiovascular, the renal pathways are multifactorial, hepatic, neurological. So there's a lot going on here with the bioactive peptide role, and they're anti-inflammatory. I mean, that's really important, and they inhibit certain protein kinase activities. And we also know that they have an ability to bind onto bile acids and prevent their reabsorption in the lower GI, which is really important for so many patients. And it's also a really important part of normal physiological detoxification. Most of the toxins that the liver is clearing from our bloodstream, most of those are going to be eliminated via bile acid, basically entrance into the GI, and then hopefully they're going to be carried out of the body with bowel movements. But if bile acids are not bound, if they're not bound to a certain type of fiber, or they're not metabolized by microbes, they get recycled in the lower GI, in the colon, and then they basically go right back to the liver and go back to that liver's overall hepatic burden. So, these bioactive peptides, again, they can be as complex as their ability to prevent the calcium calmodulin complex in heart tissue and prevent the hypertrophy that can occur there. But it can also be as simple as binding onto bile acids and clearing them from the GI. But that, again, the role in cardiomyopathy is incredible. It's as simple as this. The peptides found in hydrolyzed pea protein will bind on to calmodulin instead of that calmodulin binding onto calcium. And when this happens, you basically start to spare cardiac tissue from the typical cardiomyopathy, loss of function that occurs when that calcium or that calcification takes place. So really incredible stuff. I would highly recommend for any of our clinicians that work in the field of cardiology and you work with patients that have cardiomyopathy, congestive heart failure, I would highly recommend the use of hydrolyzed pea protein, whether that be in an enteral formula or that be something that you help that patient learn how to use in day-to-day life, if eating orally, putting that in recipes, because I think it's a game changer. Here are some other qualities that I may have touched upon briefly. They have antioxidant values. In some cases, they're significant. They have the ability to inhibit oxidation of linoleic acid, thereby reducing the inflammatory cascade. So they're anti-inflammatory. They also, in some cases, can chelate heavy metals, especially the heavy metals that have the greatest ionic charge, and that can prevent their absorption. I already mentioned cholecystokinin signaling and providing a patient with increased satiety, less food cravings, especially for carbohydrates, which is really important for a lot of our patients. Bile acid metabolism, and then this last one, decreasing zonulin production and improving occludin levels is always good for tightening up gut wall integrity, trying to minimize those gap junctions that occur with that high level of intestinal permeability that we know is an issue for so many patients, especially those on enteral formulas, where we're trying to minimize bacterial translocation from the gut. Again, I think peptides make so much sense for that population. Now, with that being said, really, as I mentioned earlier, I'm really excited to hand it over now to our clinical expert in this area, Anna Sasati. So, Anna, thank you for being with us today.
Thank you, John. So we're going to be looking at what our evidence-based, clinical research supports the use of peptide proteins in certain populations. So one of the biggest things is obviously healthcare utilization. It's how expensive it is to have patients, in the hospital or go to emergency room visits. So in this study, they looked at patients that transitioned from a peptide-based, formula from a standard protein formula. And then they looked at the symptoms of intolerance. So overall, there was a 28% decrease in these symptoms, 20% improvement in nausea and vomiting. There was a 21% improvement in diarrhea, 17% improvement in abdominal pain and cramps, and 7% improvement in abdominal distension. And there was no gas or bloating reported with the peptide-based formula. With the standard formula, there was reported gas and bloating. So 44% of patients that were started on the peptide-based formula had no symptoms at all. So the rest of them had those symptoms, but there was a significant improvement. So overall, that decreased the number of phone calls, the number of emergency room visits, and number of provider visits. So the overall takeaway from this study is that peptide-based formulas are well tolerated for any patients that are at risk for malabsorption or in those who have an intolerance to your standard protein formulas. And we know that peptide-based formulas cost a little bit more, but this cost can be significantly outweighed by reducing the cost of healthcare utilization, which we know can be pretty expensive. So the second study, we're looking at adult patients, and this is in a post-acute setting, home care setting. So there was, after a year of initiation of a peptide-based formula, there was a significant increase in patients having no GI feeding intolerance from 41% to 59%. We also saw a reduction in hospital inpatient visits from 100% to 72%. We saw a decrease of 12.6% in nausea and vomiting, 8.3% in diarrhea, and 8% improved constipation. Abdominal distension improved by 6%. And we saw cost being decreased by 11% after 180 days of being in a peptide-based formula for inpatient visits, and 3% after 180 days for emergency room visits. So again, we're seeing how reducing the feeding intolerance can significantly reduce hospital stays and associated costs. So with our peptide-based enteral therapy in this specific study, we were looking at malnourished children. And as we all know, malnutrition is associated with gastrointestinal alterations. So it increases intestinal permeability and also can cause malabsorption and diarrhea. So this study was specifically compared to free amino acid formulas and whole protein formulas. And basically what they found is improved tolerance and absorption, better nitrogen retention and balance, reduced diarrhea and bacterial translocation, enhanced fat absorption, and they maintained or restored their gut integrity, which is really important in these patients. So what are the conditions to consider use of peptide proteins? There's several conditions, but these are the ones that have been mostly studied. So the first one is going to be neurologic disorders, any post-op gastrointestinal surgery, critically ill or ICU setting, irritable bowel disease, which can be Crohn's disease or ulcerative colitis, malnutrition, if there's any cow's milk protein allergies, gastroparesis and delayed motility, any malabsorption syndromes, diabetes or poor glycemic control, cystic fibrosis, and pancreatitis. So the overall theme here is that patients with compromised gastrointestinal function can benefit from peptide proteins. So in this study, we were looking at pediatric patients, and this is in a post-acute setting. So we saw that we know that GI intolerance will frequently lead to having to interrupt feedings, not reach full goal of our calorie needs, which can definitely lead to malnutrition or weight loss. And as we already know, it's very well known that malnutrition is associated with poor clinical outcomes, increased healthcare utilization, and increased mortality. So in this study, we saw inpatient visits decrease from 100% to 63% after a year of patients being in a peptide-based formula. And the costs after 180 days were mostly consisted of outpatient visits, 69% outpatient visits. Only 28% were consisted of inpatient visits and only 3% emergency room visits. So as we know, these patients, need close monitoring, but costs outpatient is way less than inpatient visits or emergency room visits. So the conclusion was that whey protein peptide-based enteral tube feed formulas are a valuable treatment option for pediatric patients who have or are at risk of malnutrition, and they show intolerance to standard formulas. And again, these formulas help reduce hospital inpatient visits and associated costs. This study here, we're looking at how peptide formulas improved nutrition in developmentally delayed children. So as we know, developmentally delayed children have a lot of digestion or absorption limitations, and mostly because of their oral motor dysfunction, which can cause choking and aspiration. Therefore, most of these patients are exclusively G-tube fed. So making sure that they tolerate their enteral feedings is pretty important. So in here, they saw a 92% improved feeding tolerance attributed to change from a standard to a whey peptide-based formula. They also saw an 81.8% of patients stopped or decreased the need of medication. And usually the feeding intolerances are a result of their gastrointestinal dysmotility that can be from the esophagus, that can be delayed gastric emptying, and of course, intestinal dysmotility. So we overall saw that there was an improvement in feeding intolerance, and therefore the use of peptide formula allows for proper protein and protein-dependent nutrient assimilation, where whole intact proteins fail or are intolerated. So then in this study, they looked at 30 children in a long-term home enteral nutrition with peptide-based formula. And these results were after the transition from a standard formula. So they saw a 22% decrease in diarrhea, 44% decrease in nausea and vomiting. There was no reported abdominal pain, cramping, gas, bloating, or constipation. And again, we saw a significant amount in provider visits, phone calls, or emergency department visits. So, we're seeing this trend where it overall decreases healthcare costs, and it's due to the peptide-based formulas being better tolerated. So in this study, they were looking specifically at stools. So they measured the stool frequency and the stool weight. So there was 2 hospitals. They provided a high protein peptide-based formula on patients that had developed diarrhea on standard polymeric formulas. So after switching from the standard to the polymeric, from the standard polymeric formula to the peptide-based formulas, they saw significant improvements in stool frequency. So the stool frequency improved from 5 stools a day to 3 stools a day. And then when looking at the stool weight, it also decreased from 500 grams to 275 grams, which is almost half of that. And as we know, when we are having high output, high number of stools and large amount, that is an indication of malabsorption. So definitely having less frequency in stools, less weight, improves absorption. So again, they concluded that their high protein peptide-based enteral formula was effective in reducing the stool weight and the frequency in patients who had experienced diarrhea with a standard formula. So the role of peptides in the intensive care unit, we know that whenever we have patients that are critically ill, that will lead to physiological stress, which will cause inflammation, and any kind of inflammation will definitely impact our gut. So they saw improvement, nutrient assimilation, and insulin regulation, which is what John talked about. We also see that they can develop peptic ulcers due to the stress, and they can improve nitrogen accretion, reduction in hyperglycemic events, and overall improvement in visceral protein levels. So in this study, we're looking at the use of a hydrolyzed whey protein formula in the presence of active Crohn's disease. So they looked at nutritional status, disease activity, stool frequency. One of the things that was mostly significant was the improvement in the degrees of malnutrition. So at baseline, 41.5% of these patients had severe malnutrition. And after treatment, which was 12 weeks, it significantly decreased to only 3.5% of patients being in the severe malnutrition category. With moderate malnutrition, it was present in 50% of patients at baseline, and that was decreased to 20.4% after treatment, which is pretty significant. We also saw an overall BMI improvement from 20.2 to 21.1, and mean albumin levels also improved from 3 to 3.7. If we're looking at our first graph on the left, we're looking at the stool frequency, and the stools basically decreased by 2.8 per day. So at baseline, it was an average of 4.55 stools a day. After treatment, it was an average of 1.74, which is pretty significant. On our graph on the right, we're looking at the severity of Crohn's disease. And as you can see, at baseline 94.4 patients had mild to severe active Crohn's disease, and only 5.6% were in remission. So after treatment, we see that there is 0% patients in the moderate to severe Crohn's disease category. there's 15.5% with mild Crohn's disease, and 71.8% achieved remission, which is pretty significant. So when we're looking at intolerance symptoms, 77.4% of patients did not have any symptoms. The patients that did develop some symptoms were mostly rated as never or rarely present. So this means that it was pretty well tolerated. So overall, over 80% of the patients that did have some symptoms rated them as never or rarely. And then when we're looking at ICU stays and costs, you know, ICU stays can be pretty expensive. And in this significant study, they estimated cost of what an ICU stay is per day. And what they calculated was that one day in the ICU cost about $4,714 per day. So definitely reducing the days of ICU stays can significantly reduce costs. And in this specific study, they saw that the peptide-based formulas decreased those costs by 20%, which is pretty significant. And that was due to the fact that there was less days in the ICU due to GI intolerance. So as we can see here, the median ICU stay was 14.4 days because of GI intolerance. And then patients that did not develop any GI intolerance, their median ICU stay was 11.3 days. So it's about a 3-day difference. So we know that peptide-based formulas do cost more than your standard polymeric formulas. However, they estimated that the cost of the peptide-based formulas outweighs the cost of the standard polymeric formulas whenever there's improvement in only 7% of the GI intolerant cases, because it reduces on average the ICU stays by 3.1 days. So in this study, we're looking at critically ill children in the PICU, and they were divided into standard formula group, peptide formula group. So we saw significant decrease in feeding interruptions and abdominal distension in the group that was with the peptide formulas. And it decreased the feeding interruption from 4.26 to 1.73 days. So almost by 3 days again. They were able to reach full enteral feeding faster, and that was from 5.36 days to 2.6 days. And then also they improved their weight gain, whereas the patients on the standard formula actually lost weight. They also saw that there was less gastric residual volume and less abdominal distension in the peptide group versus the standard group. And they also estimated that the mean sepsis duration was shorter in the peptide-based formula group versus the standard formula group, from 7.33 days to 4.5 days. So another big one is post-intestinal surgery. And in this study, they were looking at patients that had resection and reanastomosis for ileocolic obstruction. So they divided them into two groups. One was whole protein formula on the third day post-surgery via NG tube. The second group, they put in peptide-based formula on the third day via NG tube as well. And what they saw was that the peptide-based formulas improved prealbumin levels. They had higher prealbumin levels. There was no vomiting, distension, or diarrhea in 14 out of the 15 patients on the peptide group. Only 1 out of 15 patients needed feeding postponed for 24 hours due to vomiting, versus group 1, 10 out of the 15 showed intolerance and needed feeding postponed for at least 24 hours. And we saw shorter hospital stays of 3 to 5 days compared to the whole protein formula group, which was 5 to 7 days. So we're gonna look here at a case study comparing a patient that was on a standard polymeric formula, then switched to a peptide-based formula due to intolerance. So this was a 14-year-old male, and he has chronic anoxic encephalopathy, quadriplegia, and is G-tube dependent. He has several other secondary diagnoses, including dysphagia, epilepsy, constipation, gastroesophageal reflux disease, osteopenia, history of sacral pressure ulcers, chronic lung disease. So this patient is NPO, and again, is G-tube dependent for sole source of nutrition, hydration, and medications as well. This patient has been G-tube dependent since 1 year of age when he suffered anoxic brain injury. So his previous enteral feeding was with a standard formula with added fiber, and he was having chronic constipation, only having about 1 bowel movement a week. He was dependent on suppositories, and he was on 2 different laxatives. One was Miralax, 2 doses a day, and then they had started him on milk of magnesia, 1 dose a day to help with him having a bowel movement. We saw weight loss in 2 months. So after that, this patient was changed to a peptide-based formula. There was no changes in feeding amount or rate or anything like that. It was exactly the same. And we immediately saw improved stool frequency. So now this patient was able to have a bowel movement every other day versus once a week. We saw a decreased use of laxatives. So he did not need milk of magnesia anymore. He stayed on the Miralax, but it wasn't daily. He just was needing 1 dose every other day. They did not need suppositories anymore, and no need for added fiber either. So we saw in this chart here, he started his peptide-based formula October 5th, 2022. So as you can see, there was some weight loss 2 months prior. And after starting this formula, we start to see pretty good weight gain. So overall, we had age-appropriate weight gain, 7.1 grams a day since the formula change. And we also saw that his BMI for age remained stable between 50 to 75% using the CPS CP chart. And that's the end of this presentation. So thank you for joining.
Great. Thank you so much, Anna and John. This is Laura Doherty from Functional Formularies. I'm going to moderate the question and answer session. So if you have a question, I know we've had a few that have already come in, so we'll get to those. But if you have a question, please put it into the chat box. While people are entering their questions, I do want to just let you know we do have an upcoming continuing education opportunity on April 26th at 12 Eastern Time. And it's going to be all about medium chain triglycerides. So kind of a backbone, a turn off of the peptides, going to make a turn to the fat world and talk about medium chain triglycerides. So, okay. And you can either register using that link, or we will also include a registration link when we send out your certificate of attendance for today. It has been approved for 1 hour of CDR credit. And we'll also include all the references in that email as well. So you should have that by the end of the day. All right, so moving on to Q&A, I am going to start with John here. So John, question that came in, are peptides better absorbed than free-form amino acids?
No, they're not. Free-form amino acids, of course, have approximately 100% absorption rate. However, free-form amino acids are not bioactive, so I would not put them on. I'm not going to say they're equivalent, in terms of their physiological influence. Of course, they're going to be absorbed at a very high rate, but when it comes to, some of the other influences that peptides have, those free-form amino acids will fall short. So they're not equivalent, but they are absorbed at the highest possible rate.
Great, thank you, John. Another question for you. How does collagen peptides compare to pea protein peptides?
Yeah, I mean, collagen peptides, of course, are going to have some bioactive, qualities. However, the one thing that's not as well understood by most clinicians, not just, patients, but most clinicians are under the assumption that because collagen protein is of animal origin, that it must be, a high quality protein. That's just not the case. It actually has a PD-Cas of 0 because it's so limited in terms of, it's mostly glycine. To a large extent, collagen it's about 90% glycine, so it has a very low amino acid score. It would be more digestible, of course, in a peptide form, but I'm not really an advocate for its use in most clinical settings.
Okay. What kind of settings do you think that collagen peptides play a role in outside the clinical world?
Yeah, I mean, outside the clinical world, I think people can use it. In theory, it, could support, the collagen-based, tissues in the body to provide the body with an ample pool of glycine and those handful of other amino acids that are sometimes, not often, but are sometimes the rate-limiting factors for synthesizing new tissue in those areas. But that would probably be it.
Okay, great. Thank you, John. Anna, I'm going to switch over to you for a question now. So in your clinical decision pathway, when do you consider a peptide? Do you wait until there's an intolerance to a standard formula, or are there some disease states that you'll use a peptide as like a first line? And Anna, you are, there you go, sorry. You were,
Okay, sorry, you were, yeah, you were, I couldn't unmute myself. No, not necessarily. I mean, of course, it's standard practice that when you start with, a standard peptide, a standard protein formula, and there's any sort of intolerance, that then, the next choice is a peptide-based formula. But there are some disease states that I just go to a peptide-based formula. If there's any, GI dysmotility present, or any signs of malabsorption, which can be different, a lot of different diseases or disease states can cause, I will definitely start on a peptide-based formula first and not even try a standard formula.
Okay, great. And typically, clinically, when you switch someone to a peptide formula because they're having an intolerance, how quickly do you generally see results or improvements?
So usually we'll start to see improvements within a week. Some patients, it can take a little bit longer, about 2 weeks, but I always like to trial for at least 2 weeks to really see, give it time to see the full effect, if it's going to be better tolerated than what they were on before.
Okay. And are there any clinical situations where you have seen side effects to using a peptide, or maybe a GI situation get worse, or a disease state that you wouldn't use a peptide for?
So I wouldn't say necessarily worse, but definitely, if there's some cases where there's delayed gastric emptying, or we have those intestinal dysmotility situations where we don't really see that much improvement, and they're still having, a lot of vomiting or a lot of constipation, then that's where we would switch to like a free amino acid formula, so that they're very better, well tolerated, and we just see improvement in weight gain and things like that. I think that obviously not everybody needs a peptide based formula. If there is not a presence of any GI alterations, or if it's just a regular patient that is on G2 feedings because they were poor feeders, for example, and I'm thinking about the pediatric world, but everything else seems to be intact or okay, and they're tolerating that, then I would definitely always try to go for a standard protein formula first, before considering moving on to a peptide or amino acid formula, because they are more expensive. And unfortunately, right now, with all these formula shortages going on, they can be a little bit more of a challenge to have a consistent supply.
Okay, great answer, Anna. This one's about insurance. Anna, what's your experience with getting peptide formulas covered by insurance? And when you have success at that, do you have any tips or tricks you can share with the audience about insurance coverage?
Yes, absolutely. So actually, peptide-based formulas are easier to get approved by insurances, because for insurance, it's all about reimbursement. Unfortunately, it comes down to money for them. So they get a bigger reimbursement with peptide-based formulas than standard formulas. So if they're G2 fed, automatically you will have no issues, or should not have any issues getting the peptide-based formula covered, especially if they're like on Medicaid. With commercial insurances, it can be a little bit more tricky, because sometimes they'll say, oh, we cover the enteral and feeding supplies, but we won't cover the formula, which, it's ridiculous. But there is an appeal process that you can go through, and you can appeal, and you can write a letter of medical necessity to basically advocate why, this patient needs this specific formula. But generally, I don't get a lot of pushback with peptide-based protein formulas. The ones from commercial insurance, like I said, can be the more tricky ones, but usually with a letter of medical necessity or doing a peer-to-peer, they get approved. It's just a little bit of a longer process, and a little bit of more time from our part.
Okay, great. Thank you, Anna. I'm going to switch over to John for a question here. Is whey protein isolate hydrolyzed? Does it need to say hydrolyzed on the label, or is it just, if it says whey protein isolate, does that just automatically mean it's hydrolyzed?
No, it doesn't. The isolate simply refers to the separation of whey. You can get whey protein concentrates and whey protein isolates, and the isolate is typically microfiltered, and the concentrate is sometimes whey protein that's been dehydrated. So it's just, because whey is a liquid, of course, at the initial stages of production, the whey is separated from the curds or the casein, and that liquid fraction can either be filtered or dried. And so the concentrate and isolate just refers to typically the way that whey protein was reduced and was separated from the water content. It would have to say hydrolyzed on there.
Okay, thank you. And switching gears here a little bit, but John, in terms of some of the increased concerns with more allergens to pea proteins, as pea proteins have become more common in the marketplace, is there less of a concern with a allergic response to a peptide, or does it make no difference in terms of the allergen response?
Absolutely less concern with peptide versions of any protein in terms of its potential to serve as an allergen. Typically we have these amino acid sequences that trigger some type of immune or allergy-like reaction. They tend to be much more complex than 2 or 3 amino acids long. So there's a great reduction in that risk. That being said, I know that pea protein allergies, we can say they're on the rise. The incidence overall is still pretty low in comparison to some of the other common allergens. But yeah, those sequences are so simple that they really fly under that, the length required for most allergen activity.
Great, thank you. And for the last question, John, when we talk about formulas and peptide formulas, is there more to it than just the peptide protein? Do the other macronutrients, ingredients matter in terms of the types of fats and the types of carbs and the percentages, looking at more of the big picture?
Yeah, absolutely. I mean, for the sake of this discussion today, I chose to make comparisons with those papers that I highlighted that would have compared enteral formulas that were identical with the exception of a peptide versus non-peptide protein component. If we take that now to the next level, well, absolutely. The type of fat being used in an enteral formula is an enormous difference maker, and it has really huge influences on different areas of physiology. You'd obviously want to have a higher level of omega-3s and a lower level of omega-6s as much as possible. That has a lot to do with inflammation, other areas of physiology. Obviously the types of carbohydrates used in the enteral formula. And again, I'm not just talking about absorption and kind of the utilization by the body. I'm talking about the multifactorial ways in which let's just say a more vegetable-based, low sugar, higher starch type carbohydrate source, what that's going to do in terms of feeding the microbiome, promoting the kind of diversity and the beneficial families of bacteria that we want there. Yeah, I mean, there's just so many levels, Laura, that we could look at this, but the quality of ingredients and the types of macronutrients used in these enteral formulas is, it's a big difference maker.
Great, thank you. And we did have one more question come in for Anna. So when you were talking about reflux and delayed gastric emptying, is there a situation where your team tries medications first before you switch to a peptide, or kind of which one comes first? And
yes, so for our standard practice, we always try to make formula or dietary changes first before starting medications, because these kids are already on so many medications, and we know that, like John pointed out, some anti-reflux medications do have side effects. So we definitely try to not do medication if we don't have to. However, there are those patients that is very severe, that even making formula changes or dietary changes doesn't improve as much. So then we would definitely, do medication as well. But if we don't have to, we would rather not.
Okay, great. Thank you so much. Well, y'all, it is 1 o'clock. I want to give a big thank you to Anna and John for all their time and knowledge today. And everyone who joined us, thank you for your time. As I mentioned before, by the end of the day, I will get your certificates for attendance out to you, as well as the references. But if you have any questions, please feel free to reach out to us, and have a wonderful rest of your week. Bye-bye.
Bye, thank you.
Bye, thanks, Anna.